Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
He's not a movie star, but he is a movie star for people who have cancer. Jonathan LEVINE. Dr. LEVINE is a surgical oncologist, and we were just sitting here getting to know one another, and he came up from Plantation, which is probably about 40 minutes away. Probably not too much traffic at this time in the morning. But Dr. LEVINE, you seem to love, you have this beautiful smile, you seem to love what you do, and you're dealing with cancer. How do you love cancer?
Well, you have an opportunity to make people well, and you got to view the cup half full, not half empty.
Okay, so we know of some people, and the first thing I said when I met Dr. LEVINE is, okay, you seem to know a lot about all this. Why would someone like, some of our very important people die? I mean, why do some people die and some people don't die? I guess that's really the question I have.
Well, we're learning more and more about the disease, and it's clear to us that there's genetic issues, there are environmental issues, there are fear issues. Some of the very worst cancers we take care of have historically been considered lethal. Pancreatic cancer, esophageal cancers. People have always thought, oh, you get those, you're dead. And that's not true anymore. We're much smarter than we were. Our ability to take care of them are different, and we look at them as chronic illnesses now. What I tell my patients is, first thing we talk about is I tell them that I'm their friend for life, and that my job is to protect them and to help them. And because I think that patient safety and the best outcomes we can make are the most important things. But one of my examples is I tell my patient, for instance, a diabetic, you don't cure diabetes. You can treat it, keep it under control. I will tell you, when I was a student, we'd amputate legs, we'd transplant kidneys, we'd have patients going blind. Now that's much less common in diabetics. You control their sugar, they do fine. Heart disease. My dad died of a heart attack in the 60s, just before bypass was available. Now, you bypass people, you put them on medication, exercise, diet. You never cured the disease, but you treat it, and people live a normal, natural life. And I think that's the same thing with cancers, that you can treat it like a chronic illness. So you operate on them, you give them chemotherapy, or now more recently immunologic therapy. President Carter had metastatic melanoma to the brain. It had spread to the brain. He was dying. They gave him this new immune therapy, and the tumors are gone.
Well, tell me what immune therapy is, please.
Well, you're trying to work with your immune system, and what they're working on is to genetically identify what the tumor is doing and fix it. And I suspect one day, and I tell this to my colleagues all the time, that we'll find the genetic fix for all the malignancies, and I'll be relegated to fixing hernias, taking gallbladders out, and treating appendicitis, and I'd be tickled pink because I got plenty of grandchildren to play with. And
that's really very beautiful. So there are still people dying, though, and you said something before. You were saying a lot of it has to do with fear. A lot of people aren't prepared. I mean, their attitude. Don't you think that a positive attitude can help cancer, as silly as that may seem?
Oh, of course, you have to. If you get depressed and down about it, you won't survive. I think that you've got to have a positive outlook. People ask me, what about this holistic approach? Tragically, Steve Jobs had a tumor that he embarked on the holistic approach first, and his outcome may have been different. He eventually went to conventional therapy and had a liver transplant, and it didn't really save his life. But I think that as an adjunct to conventional therapy, the holistic thought has a place. I mean, eat healthy, take your vitamins. Don't go crazy. I mean, if you take 4 grams of vitamin C a day, you probably dump most of it. But the reality is, whatever that holistic exercise, be positive. These are all part of taking care of people. And family is important. You got to have a support network. When my wife was ill, her sister-in-law made her what she used to call her chemotherapy salad. And my sister-in-law is a vegan. And so when my wife got her chemotherapy afterwards, my wife had lymphoma 15 years ago, and 16 years ago maybe. And she's alive, well, and I got to credit modern medicine. So,
well, it's so positive to hear you. The one disappointing aspect of getting cancer for me is when in my capacity as a gerontologist, is I have people tell me, well, I went to the doctor and he said, well, you have cancer and we'll try to keep you alive. I mean, I can hear you. You have a very different way of sharing. Some people even get this prognosis over the telephone. I really like you to address that, and I hope that you can speak to your, I don't know if you want to do that, but you ought to speak to your fellow physicians and explain that is not a good thing.
No, I don't give that diagnosis over the telephone. I think that's too personal, needs to be face-to-face, and also not just face-to-face with a loved one or a good friend. It's a terrible thing. But, I take care of a man. It's an interesting story. I'm a Miami boy, and my dad was a builder in Miami back in the 50s and 60s, and he had a friend who was a roofer. And my dad died in the 60s, and then I moved to Fort Lauderdale. I practice up here, been here 30 years, and I get called to see a patient who's 91 years old. And I introduce myself, and he has colon cancer. And he was in the dentist chair having a crown fixed, and he fainted because he was so anemic from his cancer. And I said to him, well, when was your last colonoscopy? He said, when I was 80, they told me I was too old to have it anymore. Now, this is a man who lives by himself, drives, exercises every day, and was told when they made the diagnosis, you're old, you should go to hospice. And to quote this man, he said, hospice, smospice, get me a surgeon. So I walked in.
He found you.
I walked in to see him and introduced myself. Turns out his daughter and I went to high school together at Gables High. He was friends with my dad because he put the roofs on my father's buildings, okay? Oh. And he made a very interesting comment. He said, Doc, when you have 100% chance of dying, anything better than dying is better.
Oh, that's great.
And so we operated on him, never turned a hair because he was healthy. He's now 97, still drives, still lives by himself. And I said to him, well, how do you exercise? He says, well, I go to Publix every day. I said, every day? He said, look, it's across the street from my apartment. I said, well, why do you go every day? He says, well, I only have two hands. Monday it's paper goods. Tuesday it's meat. Wednesday it's vegetables. Thursday, and very positive attitude. And I said, but I did ask him, I said, are you going to ever do a colonoscopy? He said, nope, doesn't matter anymore. Likelihood I make another cancer is so small that.
And he knows you now anyway,
and
right?
He knows me now anyway.
You'll take care of him, right? Yeah. Well, I'm sure he must have a lot of lady friends. That has to help.
Yeah, he does.
I can figure that out. That's a great story. So in this whole issue, of course, you are a surgeon, and
yes.
Do you do surgery? You said you do surgery other than cancer too.
Oh yeah, I'm a general surgeon, but my area of interests are cancers, particularly the really tough ones. I operated on an 80-year-old man last week who had esophageal cancer, and he's going home tomorrow. Yeah,
I'd like to talk to you about that because I mentioned that. I said, I don't know anyone who's had that. At least I've never heard of it. Talk to us about how someone gets this.
Well, esophageal cancer is becoming more and more evident in that, in our society now, everyone's got heartburn. And not that every heartburn patient gets a cancer of the esophagus, but it's becoming a more and more common problem. Historically, we used to see esophageal cancer only in smokers, drinkers, but now with reflux becoming more and more of a problem. As a society, we're heavier, we're overweight, we get more reflux. People pop the purple pill or some other anti-ulcer therapy or Tums or Malox, and they don't think much of it. But we're identifying that there's a group of people that get a cancer of the esophagus because the acid is irritating the distal lining of the esophagus, and you develop a cancer. We call that Barrett's esophagus. My mom has Barrett's, actually. Her brother died of a cancer that arose in the Barrett's. And what happens is, my uncle's a perfect example, that people have busy lives. They ignore their reflux and their heartburn. They just take more and more medicine. So my uncle's wife was ill with some orthopedic issues for 2 years. He was her caretaker because she was wheelchair bound. And he ignored his heartburn. Finally got endoscoped and found to have a cancer. At the same time, I was part of a team developing a new minimally invasive approach to the cancer. And one of my colleagues was at USC, and I asked him to take care of my uncle. Nothing to do. He died of the disease because it was so far advanced. So the key is that when patients go for their colonoscopy, if they have reflux, they should have an endoscopy to look at their esophagus.
And even though this, I guess, it's appropriate to ask you also about reflux. How if someone's listening now, you've just scared them, they want to get rid of their reflux, what should they do?
Well, they should get their primary care to get them to a gastroenterologist. Not all reflux goes on to cancer. In fact, far fewer than that. But if you have severe reflux, particularly if it doesn't get better with anti-ulcer therapy, you got to see your gastroenterologist. And the gastroenterologist should do a baseline endoscopy and then routinely do one every few years, every 5 years, just to make sure. It depends on the individual case. I'm not going to dictate how often you should do it. That's up to the gastroenterologist on a case-by-case basis. But people should be endoscoped initially and then followed.
And what do you do as a surgeon? Do you remove what do you remove?
Well, we've become smarter. Historically, much like the pancreatic cancers, the esophageal cancers had been considered lethal. And part of the reason was we weren't smart enough to understand how the disease worked. So now, if it's a early cancer, we, in a minimally invasive way with the scope, the thoracoscope we call it, and with the laparoscope, we literally cut away the native esophagus, and I pull the stomach up and make a new esophagus out of the stomach.
No kidding.
Now, it's a very interesting operation. It works beautifully. There's some side effects. You have to change how much you eat, and you can get some bile reflux, but people do pretty well, and I've got quite a few long-term survivors. But the question is, do you truly surgically cure them? We don't know. We probably don't surgically cure everyone, but we combine therapies. Again, we want to change it from a acutely lethal disease to a chronic illness. And
okay, so now I'm trying because I haven't seen this or know much about it. All right, so now you've just surgically worked on it. Now they still have to have chemo or radiation, and tell me about that.
Some will get chemotherapy, but what we're doing with our esophageal cancers now is we typically, if they're going to require chemotherapy, we give it up front. We do what we call downstage it. So if it's a more advanced cancer, we shrink it. And we're doing the same thing with some of our pancreatic cancers, some of our stomach cancers, some of the tumors that were historically bad, rectal cancers. We downstage almost all of those with chemoradiation first and shrink it down. I just did a rectal cancer 10 days ago. No residual tumor. Just a few areas of funny-looking cells we call atypical. Lost his rectum, but he is doing quite well. The lymph nodes that were involved by the cancer are gone. The cancer itself is virtually gone, and he's home. And
do you have this strange question? Do you have a therapist that works with you so that once this happens, they understand what their new life's going to be like, just as you said?
Yeah, we do. We have different kinds of therapists depending on their needs, and we work with a bunch of psychologists that are clinically geared towards these kinds of illnesses because it is a life-changing event. But I think the best therapists are actually the families. Mm-hmm. People need a support network, and I think that that's crucial. I think that anytime someone's ill, you need to have your family with them.
Or friends, because
or
so
friends.
many people,
Oh, yeah.
Don't have their families
but
anymore.
Someone
around.
should be with the patient.
People would,
like when I give the diagnosis, I insist someone's there with them. Family, neighbor. I just saw a woman in the office who has a very small breast cancer. She'll be fine. Accompanying her was actually my retired operating room nurse, who I hadn't seen in 30 years.
just by coincidence.
Yeah,
that they
just
were
by
friends.
coincidence, she was her neighbor. And she walked in. I did a double take. I said, "What are you doing here?" And she said, "I'm here with my neighbor. Didn't want her to come by herself."
Well, I don't know if you do it, but I would suggest that you have an enthusiasm pill you take. I mean, I have never had anyone, probably I'm doing this many, many years, with such enthusiasm about such a serious subject. You really have the right, your professor, your mentor really knew what he was doing when he found you. So I know you have some children.
I do.
Have you passed this on to your children? I hope.
Well, I've tried, but they're enthusiastic in their own fields. I don't have a single physician or medically oriented child yet.
It's okay as long as you pass your enthusiasm on. No
I
matter
do.
What you're doing.
I have we have 6 children, and they and 5 grandchildren already, and so yeah, we pass it on. We want them to be really passionate about what they do, and they're all employed and good jobs, and and they love what they do, and they love their children. They better.
Right, but I have to tell you something that I have never, thank goodness, other than having a partial hysterectomy at the age of 37, I've really never had any surgery, and I've really never known anyone, but I know someone now, and if I ever need anything, I'm going to be on your doorstep, because you have all the ways that I've believed that people should be as a physician: enthusiasm and knowledge and care, and mostly important knowledge. I mean, I'm fascinated by what you've been talking about. You had said also, let's talk about the pancreas. Well, I don't even know what a pancreas is good for. So tell me about that and what happens when you lose one.
Okay, well.
Can you lose one?
Oh, yeah.
Okay.
We've got some really famous people that have died of pancreatic cancer. But what's interesting is no one ever talks about the people that survive. Okay? Of course, Steve Jobs had an endocrine tumor, and it killed him because it spread from the pancreas to the liver. Then there are others, like our friend from Bonanza. He died of pancreatic cancer. Yeah, Steve McQueen died of pancreatic cancer.
I didn't know that.
And it's interesting that when they were told of their diagnosis, particularly Steve McQueen, he went the holistic route. Laetrile, apricot seeds, coffee enemas. Listen, holistic approach as an adjunct to therapy is not inappropriate as long as it doesn't cause harm, but it's not the therapy of choice. But what we've learned with our pancreatic cancers is earlier diagnosis. We're very sophisticated in the way we can evaluate it. We can, it's found incidentally sometimes, but the most common reason people come in is they're yellow, they're jaundiced, and that we pray that that's their presenting complaint. But sometimes it's more advanced. So what we're doing with that tumor is it's no longer a death knell for everyone that walks in the door. And there are different parts of the pancreas. It's divided into a head, body, and tail. And the body and tail tumors used to be lethal. 100% of the time, they were dead within a few months. I've got a lady now, she's 2 years out. And we gave her chemotherapy up front. We shrunk the tumor down. I took out her pancreas, and she's alive and well and doing fine. And
what did she do without a pancreas?
Well, she has enough of her insulin-producing cells to keep her diabetes under control. She had diabetes as one of the presenting complaints, but we've kept her from becoming too brittle, and she takes some pancreatic enzymes as a pill. It's uncommon to take the whole pancreas out. Usually the tumor does not involve the whole pancreas, but we now are sophisticated enough where we actually can look at the pancreas by ultrasound both preoperatively And in the operating room, we can actually examine it to see if there are more than one site in that same pancreas, what we call multifocal. And then some pancreatic tumors recur, in which case you might go back and cut it away again. But the key point is to make it what we call resectable, that you can operate on it. So if it's advanced in the beginning, you get rid of the jaundice by a stent, if you will, and then you give them chemotherapy, and then you can come back. And I've come back many times where we've downstaged it, as we say, made it smaller, made it operable, and then cut it away with the prayer that it hasn't spread anywhere else. And
that's my next question.
Yeah.
I have so many questions. I love having you on the show. This is fantastic. I should really mention again, Dr. Jonathan Levine, right? And Dr. Levine, you have an organization. What is the name of the organization that you're with?
My practice is Fort Lauderdale Surgical Specialists.
Fort Lauderdale Surgical Specialists. And is that just you or other people?
No, just me. I have a physician assistant.
Okay. No, I meant, but there's no other surgeon. So
Nope,
it's Fort
I'm the only
Lauderdale
surgeon.
Surgical
Specialists.
Okay. And let's have a phone number.
954-202-0242.
Okay. Perfect. 954-202-0242. Dr. Jonathan Levine, Fort Lauderdale Surgical Specialist. Whoa, I'm just enjoying this a lot. I can go talk to you about maybe writing an article, start doing something with this, but I just want to now keep going. Often we've had people with lung cancer, and it winds up that it seems like it's in remission, and it winds up in their brain. What happens here?
Well, I don't take care of lung cancers, but it's the same mechanism that other cancers
You don't
do.
take care of?
No, there's some cancers I don't take care of. Some of the urologic cancers, the gynecologic cancers, lung cancers. These are different specialists. So there's the gynecologic oncologist who took care of my mom, for instance, and she got combination chemotherapy, radiation therapy, and surgical therapy. So that's, and the same thing in these other tumors. There's some ads now. You watch on television, there's ads about everything now. But there are some lung cancers that are now being treated immunologically, just like Jimmy Carter, who had melanoma and went to his brain, and he had a bunch of tumors in his brain, and now they're gone because of immune therapy. And that's on the horizon. We're seeing that as one of the mainstays of some of our therapies, to look at the genetic basis of disease. You know, we look at cancers as to their biology. So not every cancer behaves the same, even in the same group. So not all breast cancers behave the same, not all pancreatic cancers. They are either more aggressive or less aggressive. So their biology is different. And in the breast cancer, for instance, we're very sophisticated. We can identify those that are very aggressive and those that are not. And then you change your treatment plan based on that.
Oh, this is just fascinating. I love this. Here it is, 6:30 in the morning, 7 o'clock. And I think our listeners are just sitting on the edge of their chairs because we have just 1 minute. But I have to thank you so much. There's so many more questions, but we're going to have you join us again. You really absolutely are special. You made my morning really great, and I know you've made our listeners very happy. I wanted everyone to know Dr. Levine will be one of our speakers at the Cure Symposium. And so I know people are going to come, and I was going to throw in something we don't have time because one of our specialists is a stem cells doctor, and I know that's part of the new, the new world. So thank you very much for doing this.
Thank you.
And I just hope that if people, hopefully you don't have cancer, but if you do, you want to talk to Dr. Levine. It's 954-202-0242, Fort Lauderdale Surgical Specialist. Thanks, Dr. Levine.
Thank you. Have a great day.